This is Heart Rhythm TV, and I'm Daniel Alyesh, here with a special report on pulse field ablation for atrial fibrillation. It's an extremely exciting time for atrial fibrillation care, and the era of pulse field ablation and its more wider adoption is upon us. For that reason, we'll do special reporting this specific episode focusing on the clinical considerations for applying pulse field ablation and the evidence base and data behind it. For that reason, we're joined today by our executive producer, Dr. Roderick Tung of University of Arizona, as well as Dr. Atul Verma of McGill University. Welcome and thank you.
Thank you.
Thanks for having us, Dan.
So just as a broad overview for our plan for our discussion, we want to keep this at a 30,000-foot view, understanding the big picture and application for PFA. Each one of these topics could have its own deep dive, but we want this to be a concise and useful resource for people looking to apply PFA to their practice right now. So we'll start with efficacy, a summary of the clinical trial data, then proceed to safety, doing an overview of the clinical trial data as well as the registry data. And then lesion considerations. How can we understand depth, the importance of contact and contact force, interesting data out of the registries related to posterior wall ablation, the value of ICE guidance, and autonomics. So without further ado, we'll get started on our first slide here, a summary of the three major clinical trials looking at 1-year efficacy of PFA for treatment of atrial fibrillation. I'll just do a quick summary. The first trial, the Advent trial, we're all familiar with it, looking at 1-year outcomes, an incredibly rigorous trial, 305 patients in a randomized clinical trial, randomizing PFA treatment for PFA for paroxysmal atrial fibrillation against thermal sources, radiofrequency, and cryoballoon. We look at they did a composite endpoint, pretty strict, looking at arrhythmia recurrence, repeat ablation, the use of antiarrhythmic drugs, and cardioversion. Then the Pulse-AF pivotal trial. Atul's very familiar with this, obviously. We're looking at 300 patients, prospective, non-randomized, multi-center international study. They studied both paroxysmal and persistent patients, looking at a 1-year composite endpoint of arrhythmia recurrence, antiarrhythmic drug escalation, cardioversion, and the use of amiodarone during the blanking period. They also measured quality of life. They measured and improved quality of life in that study. The third is Inspire, looking at an electroanatomic map integrated lasso-type catheter, looking at composite endpoint of arrhythmia recurrence and repeat ablation. 226 patients, non-randomized, multi-center international study. As we move to the right, one of the big picture comments is the use of antiarrhythmic drugs. Inspire had 30% antiarrhythmic drug usage. Pulse-AF looked at escalation of antiarrhythmic drugs, whereas Advent really was quite stringent with their antiarrhythmic drug usage. So I guess I'll put my first question to Atul here. Your take on the overall efficacy and 1-year data amongst these studies.
Yeah, thanks, Stan. I mean, I think across the board, you're right. There were some differences in the monitoring strategies of the 3 trials. There were some differences in terms of antiarrhythmic drug usage. But as a whole, I think what we're seeing here is more similarity than we're seeing differences. I think that if we had tested all 3 of these technologies under identical conditions, we would have seen more similarity in their results. And I think what we're also seeing, and that's clearly seen in the Kaplan-Meiers on the Advent trial, is that none of these results seems like they're drastically different from historical thermal ablation. And, that makes sense because the lesion depths of lesions created by RF, cryo, and pulse field ablation to date anyway are pretty much exactly the same.
I think we'll proceed now to to really the promise of pulse field ablation, the safety profile. I think that when you have a preferential myocyte electric field and really avoiding some of those catastrophic thermal complications, that's huge for us all. So this is a summary table. First, the 3 clinical trials, Advent, PulseAF, and Inspire. And then the 2 registries, Manifest and Euphoria. So looking at the clinical trials, you see that phrenic injury, fistula, it delivers on all those. Advent, there was a death. Overall complication rates looking pretty good. And then as you progress to Manifest and Euphoria, the severe adverse events are pretty similar to looking at Advent. And then you see phrenic injury coming into the fold. I guess, Rod, I guess what's your take on overall safety of PFA, looking at it in clinical trial as well as clinical practice in the registries?
Well, as Atul mentioned, the biophysics don't appear to be significantly different with regard to lesion depth, but I think the goal and the hope was that there'd be increased durability. But we also have to understand that it's possible that the success of PVI might not be predicated upon durable PVI, which I think most people don't want to believe. And I don't think it's the right message to say that shouldn't be the target. It clearly should be, but there's clearly a lot of things that we don't understand mechanistically. And that we've all seen veins isolate and AFib terminate, but we've also seen AFib terminate when veins don't completely isolate as well. And we don't really know how many patients are doing well with veins that are wide open. There was that study from Hangzhou that Chen-Yang Jiang did that showed that almost 90% of patients that were successful still had open veins, at least 1 or 2. And one could only imagine that that probably is the case, but clearly our goal is still durable PVI. I think once you start getting to more real world, like Manifest and Euphoria, and you start putting this in the hands of all electrophysiologists rather than those that were early access people that were in the development of it, you're going to see some diminution of effect. But I think that the absence of fistula, the ability to potentially do the posterior wall and restudy the posterior wall, and then the absence of a permanent phrenic injury are huge favorable benefits. Because if you can get in there and do something that's more efficient and then do something that is a lot safer, then I think the adoption of AF ablation will be much higher in the general cardiology community, the heart failure community.
Yeah,
So go ahead.
no, sorry, Dan. I was just going to say I fully agree with what Rod just said. Pulse field ablation really only had to deliver on 2 out of 3 things. Efficacy, it's clear it's going to be about the same. But if it can be safer and it can be more efficient, then I think it still wins. And you're right. I mean, there was one phrenic injury that was seen in some of these registries. But that rate of phrenic injury is still far, far lower than what we see with cryoballoon. And for me, I kind of said at the very beginning of all this that if I never had to worry about a fistula again, that was it for me. So I think those are key items.
Yeah, I do want to emphasize the esophageal markers because, Shiv and our group were trying to put balloons in to protect the esophagus. There are probes that are circuitous with multi-electrode to prevent this rare but terrible, terrible complication. And once you've had one, you'll do anything to have to not worry about it. So there's a huge advantage there. Particularly, if we're going to re-embark in posterior wall studies.
Absolutely. Yeah. And I think that a couple of things that jump out at me. One is the perforation rate. I think it's comparable to a degree. I guess, my understanding is understanding how to lead with the wire and to avoid traumatic conformations particularly related to Farapulse can be helpful here. So the perforation rate, at least out of Manifest and Euphoria, with experience can improve. The other question I have for the broader audience is the data on silent cerebral lesions, and sheath management, and the risk of air embolism. I guess Atul, I'll put it to you. Can you comment on that?
Yeah, I mean, look, size matters, as we always say. And, if you look at the Farapulse catheter and the Farapulse sheath, the outer diameter of the Farapulse sheath is 17 French. I mean, we're putting big sheaths and big catheters into the left atrium. And so, yeah, you have to be very meticulous about sheath management, air management, accidentally entraining air as you pull the catheter out and push the catheter in. We have to get used to that kind of workflow because most of us have not used catheters or sheaths that large before. So I think that's a very important contributor. Yeah, there were some early concerns about silent cerebral embolism, with the microbubbles that are forming. I think what we've seen from more recent data is that a lot of that microbubble formation is hydrolysis, which really shouldn't cause any major brain effects. And as you point out, I think there are other contributors like accidental entrainment of air and air embolism that may be contributing to this. But hopefully, as people get more used to the workflow and more used to these sheaths, and more used to flushing and aspirating, I think we'll hopefully see a reduction in this.
And fewer exchanges and all that will be helpful. And then also my understanding of the phrenic nerve injury is, and anyone correct me if I'm wrong, but delivering PFA, particularly as it relates to the right-sided veins and the right superior, you need to be sure that you are not within the ostium and maybe a bit more antral to avoid that risk. I mean, only one, you're right, is much less, but clearly there is a consideration, and we can learn as we move forward. So, this is a pretty interesting study that came out recently in JACI P, the concept of hemolysis in PFA procedures. And in my read of this study, it seems as though we should expect a certain amount of hemolysis in all patients. But then once you get to a level or a threshold where the hemolysis exceeds the haptoglobin's ability to neutralize the heme, you can have acute kidney injury. And so in this study, they talked about the role of hydration, and particularly 2 liters, to prevent this acute kidney injury. I think if you look at the number of pulses they're using, 32 for the non-acute kidney injury to 57, those are pretty high. But I think, Rod, you always talk about sinus rhythm therapy, right? For patients with cardiomyopathy, how powerful it is. And often those patients have a more advanced AFib. So what does this mean for the implications of treating patients with advanced AFib substrates, particularly who are fluid sensitive with cardiomyopathy? And Rod, I'll let you take that.
Well, this is a new development, right, in the narrative of PFA. I think many people started hearing about spasm and then started worrying about that, but we understand that that might be in specific locations. But this one does appear to be dose dependent and related to the number of applications. And obviously there are newer evolutions of technology that may shield the amount of surface area of the electrodes with the actual blood pool. So there will be future developments to mitigate this. But I think that this is obviously a very serious concern, because the last thing you want to do is take someone that's a healthy outpatient and all of a sudden put them in a renal failure on a de novo atrial fibrillation. So very important for us to study and understand this a lot better. But I do believe that if we're going to be prescribing sinus rhythm therapy with GDMT for heart failure patients, and we need to worry about volume shifts and aggressive hydration, that's a whole different protocol. So very important that this is revealed for us to be able, because it does appear to be real. And I would say for the initial cases that we've been doing, because we've been on some of the early wave in the US, we've been checking LDH and haptoglobin as well to try to understand our incidence of this as well. But we're trying to keep all the applications well less than what's reported. And that's obviously the global concern of such an efficient system like this could be in the wrong hands a weapon of mass destruction. And you want to obviously deploy this in a thoughtful and very judicious way. So once you get to a place where someone might have multiple flutters, or you start getting into redos and this is going to start expanding beyond PVI, that's when you start seeing that there might be more than 50 or 100 applications. And I think that's when this risk is potentially self-protective. If people are aware of this, then there is a limit to how much we should be doing, not just to obviously spare whatever chamber we're doing, but I think it's a good word of caution here.
Atul, I thank you, Rod. Atul, I think that, we had a nice discussion with regards to the early development of PFA and our understanding of as this always being an issue. Can you give us your insights into that and designing catheters? And
Yeah, so, actually, I had the privilege of being able to get involved with this many years ago. And from the cancer literature, hemolysis was always well known to be a problem with PFA. And, fortunately, in a lot of tumor treatments, you have tiny little needles which go into the tumors. And so you don't have a lot of exposure to the bloodstream. But as they tried to do larger and larger catheters, this was an issue. So I don't think it should come as a shock or a surprise that this happens. The real question is, as Rod said, how do we shield unnecessary field from going into the bloodstream? And I think when you look at some of the newer catheter designs, first of all, some of them are going to be small. If you're delivering PFA off of a point-by-point catheter, I don't think this is going to happen. If you have a balloon type system where the balloon is shielding the elements that are facing towards the blood, I think that's going to minimize it. But, look, this is a first generation PFA system, first out of the box. And so it's not surprising that we're seeing some unexpected things. The only other thing I'll add here is that there may be a myoglobin effect here too. Remember, there is some musculoskeletal recruitment, more so with some systems than others. And, if you look at this same study, the myoglobin levels tripled or quadrupled after the deliveries. And so I think we also need to measure myoglobin in the urine as well, because if you have both hemoglobin and myoglobin, it's a deadly combination for the kidney.
yeah, I agree. I think moving forward, we need to understand who these catheters were designed for and probably what substrates they're best for. And then as we learn more, kind of adapt that. But thank you both for a great discussion there. Moving on now to another area of, of interest or concern, it's the coronary spasm. And, this study looked at where do we see coronary vasospasm in the context of PFA. And noticing that the CTI region is an area of concern, as well as the mitral isthmus, with concerns for the RCA and circumflex respectively. Now, it looked like both these circumstances, it could be mitigated either with intracoronary nitroglycerin or IV nitroglycerin before. The authors then go on also to comment that actually in our RF literature, there is evidence of vasospasm already as well. Many of these vasospasm events did not result in ST elevation. It's really more, they did the angiograms, they saw mild and moderate and severe vasospasm. It also did not result in ICE determined wall motion abnormality, but clearly something we all need to think about. So I'll put the question to you, Atul. Thinking about vasospasm, how do we apply nitroglycerin, and how do someone who's trying to apply this to their clinical practice, how should we think about this?
Yeah, so I think the good news on this is that intravenous nitroglycerin can be used to prevent this. So we don't have to suddenly become coronary angiographers and start putting intracoronary nitroglycerin. As Rod said, this only happens in areas that are very close to the coronaries. So the CTI and the mitral isthmus in particular are high-risk areas. I suppose the bad news is that the doses of intravenous nitro that we're going to have to give are going to be very, very large. We're talking about 2 to 3 grams of IV nitro, whereas we usually measure it in micrograms. So that's a lot of nitro. And you're going to have to chase that up with phenylephrine and other pressors to kind of prevent the hypotension from that. So there is a recipe to prevent this. The recipe does add a little bit more complexity because of the risks of hypotension and managing that. But I think, again, as people get used to it, and maybe the CTI is just not a place where we should go with PFA. I mean, maybe we do need to pull out RF catheters, and many dual purpose catheters are going to be coming out where they deliver both PFA and RF, and maybe we just choose RF for these areas.
Right, and this is with a larger footprint catheter that this has been mostly reported in. So it's possible that, with single point ablation catheters, this will be less likely. But I agree with the tool. This just might not be the right application for this technology. I don't think that we struggle so much with CTI, acute block and durability. I think the ones that are the toughest might be the ones where the topography is the hardest, where you've got a huge eustachian ridge or multiple trabeculations or pouches. Those would not be favorable for large footprint catheters as well, because contact is still necessary. It's not even sufficient. You still need a little bit of contact force. So I think it might just be the wrong indication for this technology. And, if I were trying to see the future, I would say that this probably just should not be thought to be the primary CTI tool. I just don't think that's where we have needs clinically.
So Rod, I'm going to push you just for a second here, just as someone who lives in the ventricle a little more, maybe a little bit like myself, LV summit ablation, right? I don't think LV summit arrhythmias are as rare as we think they are. And so, we always have the old adage of distance to the coronary is 5 millimeters. And, I guess, what does that mean for the application of PFA in this area? Because I think, we would love to have another tool in our tool chest for LV summit ablation.
Well, I think it'll depend on the size of the catheter, but I would caution that would be potentially the worst area to look at this. We obviously would hope that in the ventricle, this would create deep lesions, but as Dr. Verma already said, it was not designed for that. So we might need to resequence or redose or relook at that for the ventricle. But if you're talking about a distal PDA spasm versus a left main spasm, I think that's pretty clear which one we would rather see. And I think once you're preloading nitroglycerin on every LV summit prior to doing this and risking left main, and we've got to reconsent patients in a different way, then I think we've lost the game. So I think it might be good to explore in really refractory cases. But I just believe, again, that we have a lot of alternatives already. And it might be a technology looking for an unmet need, but it might not be needed here either. I think that maybe what we need to still figure out is ways to enhance radio frequency or intramural delivery. And there's a lot of work on bipolar and multi-electrode and half normal saline, that this might be the one that I would go to last in the LV summit location.
Very well said, Rod. Thank you. So I think we've all alluded to this, the nature of the lesion, right? How deep is the lesion from PFA? What matters in delivering a durable lesion? Now, I think that the messaging or the thinking has really shifted from we need to be close, we need to be in touch, maybe we need to have some contact force to deliver a durable lesion. Both these papers are from Hiroshi Nakagawa, as well as the latter is with Luigi DiBiase. And so the initial paper you see here, looking at a focal PFA catheter using a biphasic and monopolar setup. In vivo swine model, looking at the importance of contact force. And as you see, lesion depth does change with contact force. Now they're going pretty high with their contact forces as well. And they describe 3 separate zones for your PFA lesion: your dark central zone, your pale zone, and then your hyperemic or your red zone. The irreversible lesion, I think, stops at the pale zone from what they said, but they do remark in that first study that there is an area of reversibility and that lesions got larger with more contact force with the focal catheter. They then went on to apply it to the multi-electrode catheter to try to develop an index, which they did successfully, so it seems. Now they make the comment of contact force in relationship to PFA and pulses. There is an interplay there, and maybe contact force is not as, I mean, I guess the lesion depth is not as dependent as with RF, but there is a relationship. So I'll start with Atul. Can you comment a little bit about these data, your own data, understanding how do we deliver durable PFA lesions and the importance of contact?
Yeah, so contact is indisputable. We need contact. The issue of contact force becomes a little bit more nuanced. I think you can see from Hiroshi's data that, you know, once you're above 10 to 20 grams of force, the additional application of force really hits a bit of a plateau. And we did separate data with contact force and showed actually that plateau happened after about 10 grams of force. So, you know, it may be necessary that we apply a little bit of force on top of the contact, but you know, whether it makes a difference, whether we're at 10 or 60, I don't think we're going to be aiming for super high forces anyway, because then the risk of perforation and everything else becomes an issue. There are 2 other things I want to point out. One is if you look at field modeling, when you have a certain pulse and a certain dose, there's a certain predetermined depth that you're going to get at. So I think the additional depth that you're getting from some of this is just turning that reversible zone into an irreversible zone. But beyond that, you can't get any deeper than that. And the other thing I want to point out is that 35 amperes of current delivery, that's on the very high end of things. Now, of course, it depends on the pulses and everything like that, but that's really starting to get right to that thermal edge. And so, you know, whether we'd want this in the atrium as opposed to the ventricle is a different issue. But contact, yes. A certain amount of force, yes. How much the rest of force makes a difference, still to be seen.
I think it's a really important context, understand durable lesions and lesion depth, because, you know, this takes us to our next discussion point, which is the manifest trial data, looking at posterior wall ablation with the FARAPULSE system, and really no effect on 1-year outcomes with regards to atrial fibrillation in persistent atrial fibrillation models. Now, Rod, you've done a lot of work in this space, understanding the posterior wall, understanding the importance of transmurality, as we know with Converge and some of the data regarding Vena Marshall. And so I guess I'll ask us, how deep are we getting with these lesions? And what does this mean for posterior wall ablation, Rod?
Well, the whole goal of PFA was to potentially redo a lot of the studies we previously did with RF to be able to have more durability. And I still think that we don't fully understand the durability of these 540 patients that were done. I want to emphasize these were non-randomized data and not very well balanced. You can see it's 400 versus 131. So I think this is exploratory. but interesting, but also highlights the other 5 to 7 randomized trials that have not shown value in the posterior wall. The only one being the Converge data, which was obviously done with a different sort of technology with epicardial. So the jury's still out with posterior wall ablation. And I think what this does is just really gives more rationale for exploring this in a randomized trial prospectively. So I think we were all hoping to see this to be looking a little bit better. But again, the mechanisms of why posterior wall isolation helps every patient remain unclear. You know, we understand Andre and Natali's idea that there's shared embryology. We have all seen patients with posterior wall triggers with ongoing AFib with a box isolation. We have all seen that. But again, the big Achilles heel of atrial fibrillation is not all patients have that same mechanism. And when you broadly prescribe one extra PV lesion set and expect it to benefit every patient, I think that's when we start getting into trouble. So if you're really purely evidence-based, there's no data for the posterior wall to be done at all, you know, systematically. But that's where I think tailored approaches do have value.
So I completely agree with you. I think the challenge, right, is the roof can be quite thick. Additionally, you have Bachman's bundle and you have fatty tissues. We've struggled with RF to get deep enough to durably treat that area. So I guess I'll put this next question to Atul. How deep are we getting? Is it deep enough to treat that roof with PFA?
Yeah, so I think we had discussed this a little bit before, Dan, but you know, all of the biphasic, bipolar PFA systems that are going to get approved either now or in the next year have really been tuned to the atrium. So if you look at the preclinical models, they're giving you about 3, at best 4 millimeters depth. And, you know, that's great for the majority of the left atrium. But as you point out, the roof, the LAA ridge, the septum, we all know that those can be considerably thicker and more challenging areas to go at. And I don't think these large catheter bipolar biphasic systems are really going to offer that much advantage over RF or cryo for those particular areas. Now, when we get to monopolar point-by-point systems and, you know, start getting into 5 or 6 millimeter depth, then we can start more accurately taking a look at what PFA can offer us. But just a matter of warning that, you know, we can't expect these systems that were designed for the, you know, majority of the atrium to deal with these thicker areas.
Thank you. So, you know, I have a bit of a bias with regards to ICE. I think there's no better anatomic tool in the procedure to see what's going on than ICE. These data were kind of sub-study data from Impulse PEFCAT and PEFCAT-2 looking at optimal waveform substrates and really showing more durably isolated veins with ICE guidance. Now, this is early. I recognize that. And we really need to write the story on ICE guidance for PFA. I know it's not common to do it in European practices and in many other practices. I guess I'll put my this question to Rod. The value of ICE guidance for what we're doing with PFA. What's your take?
Well, certainly, you know, you're looking at surrogates for proximity indicators, and everyone wants proximity indication, but there's nothing better than real-time visualization. And I do believe that ICE has delivered on the promise that real-time MRI just has not scaled out to be. And you can obviously not only see tissue apposition, you can see when catheters actually bend slightly, and then obviously watch lesion formation in the case of rate of frequency. So I think ICE has been one of the potentially the greatest advances in my time from fellowship to being an attending, because we used to just use it as a tamponade monitor and to assist transeptal. And we're doing so much more with it now. As a matter of fact, I won't do a single RF lesion without monitoring on ICE these days. So I would just extrapolate that to PFA as well. In our early experience, we have been doing zero fluoroscopy, and I'm not saying that should be the goal, but it certainly is doable. I know Dr. Nair, Devi Nair has been doing that as well. So I think it is doable with a lot of these systems. And there's no reason as to why it should not be employed. We understand that the finances are quite different across areas around the world.
Atul, your take, having been involved in so many of these multi-center studies, the ICE groups versus not, where do you see this technology going as far as ICE and application for PFA?
Well, look, the systems that are coming out right now, the ones that are approved in the US, are not necessarily married with mapping, right? So you don't have the benefit of an anatomical map. If you do make one, you're making it with another system where all the parameters don't communicate with one another. We have no sense of proximity contact. These early versions do not have contact sensing on the catheter. So ICE then becomes really your only tool to assess whether you're truly in contact or not. And I'm also hugely biased in this regard. I love ICE. I use it for all atrial and ventricular cases, and I think it's incredibly helpful. But we know that our friends across the ocean are not able to use it, and also claim quite strongly that they don't need it. But I think it's a great tool, especially since we have no other feedback mechanism at the present time. That'll change. But for now, we don't have it.
So I think we'll conclude with this final topic, autonomic effects. Those that have used the PFA systems notice an acute effect, specifically related to the left-sided pulmonary veins and bradycardia. But 2 clinical studies have shown that these autonomic effects are temporary. The first being a study where they mapped the plexuses, they compared it to thermal treatments and PFA treatments, and they actually stimulated the plexuses and even remapped some. And so there's always that dogma of, an increase in 10 heartbeats per minute, right, post AFib ablation may herald a good outcome. And it has been controversial as far as autonomic targets for AFib. Some studies showing benefit, others not. So in this case, the thermal sources did show a difference with regards to autonomic durable effects, whereas PFA was transient. And then again, they did another study. These are both in JACC-EP, looking at comparing cryo thermal ablation with PFA, and they used a serum biomarker, which S100, which is a surrogate for autonomic effects, showing a difference with cryoballoon that was durable and a much smaller difference with PFA, even when normalized to these silent cerebral lesions. So I guess I'll say, what does this mean for the autonomic theory for AFib, and what does this mean for application of PFA for treating autonomics? And I'll start with you, Rod, as you have pioneered a lot with CNA as well as understanding autonomics. And so what's your take on this?
Well, incompletely understood would be the summary. We know that surgeons that directly stimulate the GP epicardially and then obliterate them with surgical tools, they don't necessarily have a better outcome. So the GP story is not complete, and it certainly is not conclusive that it needs to be done. But we do understand that the mechanism of AFib ablation is probably beyond PV isolation and may have these effects, but there are autonomic effects beyond just GP. If you look at anything that the UCLA group is doing, anywhere there's muscle, there's nerve. So it's not just GP or bust. The other thing that I would just point out is that you can have an autonomic response in a region that's not at a GP with a lot of this. And Dan, as you know, you're doing CNA, and how come the first place that you ablate all of a sudden creates a vagal response? Well, maybe just banging someone's elbow creates a vagal response as well. So it might not be the direct nerve that's stimulated at that exact spot. It might just be a noxious stimulus or a mechanostimulus that creates then or elicits a visual gerish, et cetera. So I think we just don't fully understand it, but it does appear that with these data and other data that you're seeing less changes. But then if then you take a look at the advent data and you say, well, they're relative equivalent, you can only indirectly hypothesize that maybe the autonomic effect is not the main reason why PVI works. And I think that that is pretty clear that that's not the major reason why PVI works. It still has to do with destroying the PVLA junction. So I think still lots to be learned, but I'm grateful for studies like this that are really mechanistic.
Thanks, Rod. Atul, I want to press you, say, ask your opinion. What does this mean for the autonomic theory for atrial fibrillation? As well as, we're looking at 1-year data, are there implications for autonomics, for recurrences? And what's your take on all that?
Yeah, so I think we need to be careful because I think that these catheters, the PFA catheters, are just not penetrating enough to actually get at the GPs. That's because if you look at, for example, the epicardial work that Atrian and some others have been doing to get GPs from the epicardial surface, it turns out that PFA is great for destroying GPs. In fact, the only cell line that may be more sensitive than myocardial cells to PFA are cell bodies that we see in GPs, not actinated nerves, but GP cell bodies. So GPs are actually very sensitive to PFA. The problem is that we know that the depth of PFA is limited, and we also know that fat is a very good insulator for PFA. So if you've got any epicardial fat between the catheter and the GP, that's probably deflecting more than 50% of the field away. So, I would strongly encourage people to read up on the epicardial work that's been done with PFA and cell bodies and autonomics, because you can actually get profound autonomic changes post-ablation when the GPs are actually properly targeted. But if they're hidden under layers of fat with a catheter that only gets you 3 to 4 millimeters deep, you're just not going to get there.
Thank you. Thank you very much. Thank you both for joining us for this PFA special report. I think it's a very exciting time, as I said, to be an electrophysiologist, and we're all clamoring to understand how best to apply this new technology, which has been subject to very high expectations and has yielded some promise for us with regards to a safety perspective. I'll put a final question to the group. Future directions for PFA. What is most pressing that we need to understand about this technology moving forward?
I can lead there, Dan. And again, thanks for doing this episode. It's just an exciting time to be an electrophysiologist because we're learning so much together. We've seen the narrative change from non-contact, non-thermal to, wait, we need contact. And yeah, it does sometimes generate thermal. And then we're now looking at potentially introducing other and anticipated, if you're like a tool and you were in early with hemolysis and spasm, but I think for the general population, for the general treating electrophysiologist, they were like, wait, I thought this was going to be much more efficient and much safer in all regards. So I think there are specific considerations as we're learning this. The only thing that I would say that we really clearly need to understand is the durability and lesion depth, which cannot always be known in humans until we start remapping. So I think in 6 months, and obviously we'll be looking at this video 10 years from now, so we have to be careful what we say. But in 6 months, we're going to have a much greater understanding. And you did see some of the remapping data come out from Europe, which did not show 100% or even 90 or even 80%. There was a significant incidence of reconnection. We don't know whether you need to remap with dedicated tools, but the reason PFA presents a challenge is because it's the first tool that can completely eliminate an electrogram in an area that is not permanently eliminated. That's the first tool we have that. And that, I think, could actually be an Achilles heel of electroporation, because no signal is actually not good. We always complain that what we're doing is purely electroanatomic. Well, now it's purely anatomic when there's no electrical signal at all in the region of interest. So then you're just basically connecting dots and making sure things look like on a mapping system or a fluoroscopic system that they're contiguous. So I think that presents a huge problem. And if you really quickly go through something, you actually have the potential to falsely believe that you've done more than you have. And that could be an Achilles heel of electroporation / pulse field. So a lot to learn, but I think remapping studies will be the greatest educator for us.
Thank you, Rod. And Atul, your thoughts?
Yeah, I completely echo what Rod was going to say. I was going to say two things: depth and how to determine when we're done. And that's it. Depth and how do we know when we're done? And I think the great news on that front is that there already are developments underway on both those fronts. So when we look at this video, 5 years from now, we'll be laughing because hopefully those solutions will already be implemented, and we'll say, gosh, we were fretting about nothing. That's my hope anyway.
Awesome. Well, thank you both for your time, and thank you everyone for tuning in to Heart Rhythm TV.
Thank you.
Thanks so much for having me.